Okay. Then we go to the second case. Tamara is a 47-year-old woman, works as a teacher. She's married to John, a storeman, for 20 years. She's gravida 2, para 1, had a normal vaginal delivery 19 years ago. She is now unexpectedly pregnant. Last menstrual period about 8 weeks ago. She comes to the antenatal clinic to see you and for the booking. At that stage, her BMI is 29. The past medical and surgical history is that she has essential hypertension diagnosed 5 years ago. She is currently on Coversil 5 milligram daily. Has been changed to methyl-dopa by GP when the GP found out she was pregnant at about 5 weeks gestation. She has no non-allergies. She doesn't smoke and really no alcohol. When she comes to the first antenatal clinic, the booking blood pressure is 140/90, and she has no proteinuria. She was offered to have a first trimester screening, which come back as a high risk for trisomy 21. The risk is 1 in 104. She chose to have a non-invasive parenteral testing, or known as a harmony test, outside there, which come back as negative. And she's happy with that. So she comes back to clinic about 16 weeks, and at that stage her blood pressure is 106/105. She still have no proteinuria, and she's well otherwise. So I have had the privilege to work with Dr. Erin Clark at Women and Children for many years, and I sit normally in room 7 and Erin in room 8, and it's very good because you just go and knock on the door. So Erin is a consultant obstetrician physician both in the private sector and one of the staff at Women and Children Hospital. She trained here and worked in the UK and United States. She has had a special interest in cardiovascular medicine and developed a love for women's health care during the her training here in Adelaide. Well, we are going to ask Erin really to talk mainly about the hypertensive aspect of our case, but also she's going to give us a more general overview of the impact of pre-existing health concern in the older pregnant woman, and the impact of age upon the cardiovascular system.
I guess I thought I'd start off with what do we define as old? It really depends on sort of who you're talking to. If you're working in the general medical wards, you don't get old until you're at least 75. If you want an ACAT assessment and you're looking at residential care, 65. Very, very difficult to get residential care for anyone under the age of 65 with a significant disability. For the purposes of this forum, 40 to 45 is probably the age group, or over 40 to 45 is probably the age group we're looking at. But in reality, for pregnancy purposes, from a medical perspective, 35 and upwards is the age at which a lot of the things that make a pregnancy more high risk start to kick in. And of course, if you're wanting cheap airline seats, once you're over 2, bad luck. Now, I've heard women compared to fine wines and such like. You know, we mellow with age. And the sort of things that happen as we're mellowing. We have changes in our skeletal composition, we have changes in our muscle mass, our lean muscle mass particularly, and in muscular function, and growth hormone is involved in this. Along with this goes a reduction in the metabolic rate, decline in our activity levels, and in our energy requirements. You know, all part of these metabolic and endocrine changes. More importantly and more pertinently, I think, for not only Tamara but also Maria, there are atherosclerotic and fibrosing changes in vessel walls, both arterial and venous. So you get reduced compliance in the arterial walls, leading to a gradual increase in blood pressure over time. All of these things occur on a spectrum. They don't sort of suddenly kick in at a certain age. And there's valvular incompetence in the veins, so you know, poorer venous return, and other things. There's also, interestingly, a loss of cardiac reserve. At 20, if your heart was asked to, it could put out 10 times your cardiac output, assuming there was nothing else wrong with it. But once you hit 30, you start to lose that ability to draw on your cardiac reserve. And again, this declines gradually. It never sort of drops off precipitously, But in an otherwise healthy heart, there is a decline in cardiac reserve and the amount that's available to you. And that becomes important not only through a pregnancy, but also at the really critical time around delivery. And I believe Prof. Bryce is going to be talking about that one. But the big three things that really kick in as people age, and women in particular, I'm focused on at the moment, we gain weight, our blood pressure goes up, and we're more likely to have type 2 diabetes. It's hard to find the rates of these things, but these factors are cumulative, and once you start adding them all together, you start to increase the risk for both a woman and her fetus through a pregnancy. Now, I hope you can see this. A lot of these are sort of cut and pasted from the Australian Bureau of Statistics, various reports and websites. This is quite an interesting graph. It is male and female, so there's no gender specificity, and men on the whole have slightly higher rates of obesity, hypertension and type 2 diabetes than women at their relevant age groups. But it does show that not only is there an increase in BMI or increase in the rates of obesity with increasing age, but over time we're seeing higher levels of obesity, and the biggest increase in obesity has been in the sort of 30 to 45 age group, which is the age group that we're looking at when we're starting to talk about women having pregnancies at advanced ages. Blood pressure goes up too. And you can see from about 35 onwards it starts to climb, and it takes a fairly steep climb after about the age of 45. Again, these are figures for both men and women. But roughly a third of Australians over the age of 18 have high blood pressure, more men than women. Of these, more than 2/3 are suboptimally controlled or not on any medication at all. That's a reasonable number of people. In the time frame that they were looking at, it was something between about 3 to 3.5 million people. So about a quarter of men and a fifth of women over the age of 18 will have suboptimal blood pressure control. And the older you are, the more likely you are to fall into that age group. And again, I'm sorry about the quality of this slide, but you can see under the age of 35, for women, the chance that you have suboptimal blood pressure control either on medication or not on it at all is around 5%. It doubles by the time you get to 35. It jumps again at 45. Type 2 diabetes as well. This is a fairly recent snapshot. The NDSS has a range of helpful resources, and they produced this as of 30th of June of this year. The number of Australians between 21 and 39 with type 2 diabetes was about 33,000. Over 40, between 40 and 70, that number shot up to almost 300,000. You can see diabetes really increases with age. And in the text box on the right, 215 people with diabetes were 15 or under, so not too many. Almost 800 with 16 to 20. By the time you got 20 to 30, you were looking at 5,500. So there really are quite incremental jumps once you get beyond about 30, 35 as well. And why is this relevant? Well, because all of these conditions are associated with higher rates of both maternal and fetal morbidity, and there are implications for maternal mortality. Your direct obstetric causes, it makes sense, and those of you who've worked at the Women's and Children's over the last 2 years will be all too aware that a 55-year-old heart subjected to intrapartum hemorrhage of 2 to 3 litres doesn't come through it quite as well because of the lack of cardiac reserve, because of the poor response to insults, as compared to someone whose heart is 25. And it's in the developed world, places like Australia, Northern America, the UK and parts of Europe, it's the medical causes that account for about 80% of maternal deaths, and they are cardiac causes, thromboembolic disease, psychiatric malignancy and other medical conditions come down. The more direct obstetric causes, while very important in the developing world as a significant cause of maternal death, we're better at those, but they still do have a higher risk or higher a rate amongst women who are older. But even if you don't have one of those big three, even if you are like Maria, BMI of 24, normotensive, no diagnosis of diabetes, your advanced age will still give you an increased risk of a number of pregnancy-related problems. Gestational diabetes is the big one. Hypertensive disorders, including preeclampsia, are more common in women over the age of 35. It's very difficult to pin down the exact numbers in women over the age of 45 because, as per the slide that Amy showed you at the very beginning, the absolute numbers of women, particularly having a first pregnancy, but even subsequent pregnancies at that age, are quite low, and so it's hard to draw a lot of conclusions from them in the literature. They're more likely to have growth-restricted or at least small babies, more likely to need or be advised regarding preterm and operative delivery, and more likely to develop thromboembolic complications postpartum. And really just focusing on some of the hypertensive disorders, both of the cases that you've seen have a high rate of high risk of hypertensive disorders. Maria, if she does go on to have a pregnancy, even if it is with a donor egg, and Tamara with her natural conception. The risk of developing preeclampsia is increased threefold if the maternal age is greater than 40. Chronic hypertension is a higher risk, the relative risk of 10, but maternal age is actually a higher risk factor than either obesity or type 2 diabetes. It's not just that they are more likely to develop preeclampsia, it's that their outcomes are likely to be poorer. And some registry data from Finland over the course of 10 years suggested that if you had your first baby over the age of 35 and you developed preeclampsia, you were more likely to require preterm delivery, you were more likely to get a section, and your baby was more likely to end up in NICU than if you had your first baby and developed preeclampsia under the age of 35. And this, they as far as they could, controlled for other pre-existing maternal health conditions. It really appeared to be an age-related thing. And this probably is more commonly what I see. I only see a handful of women in their 40s and 50s, but I do see a number in their late 30s. This is a lady that I saw within the last month. She's 17 weeks in her first pregnancy. She's got an elevated BMI. She's known to be hypertensive. At 17 weeks, she's already on 2 grams of methyl dopa and 60 milligrams of nifedipine per day. She thinks she's going to deliver at Burnside. I haven't broken it to her yet that she might want to reassess her delivery plans. But it's not that simple. It never is. And when you look at the Australian data, there's a bit of international data, but looking at some more Australian data, Victorian population, hopefully comparable to ours, they compared pregnancies in women over the age of 45 to pregnancies between 30 and 34. There was a greater risk of GDM. The odds ratio was 2.05, and the numbers afterwards are your 95% confidence intervals. Greater risk of antepartum hemorrhage and placenta previa, and these things are all known. If you had a higher risk of preterm delivery, even as a singleton, even with a natural conception. Of course, if you had more than one baby on board or had gone through any kind of assisted reproductive technology, your risk of preterm delivery was earlier. Lower birth weights were more common only in women for whom the first pregnancy occurred at 45 or older. If it was not their first pregnancy, they didn't have the same trend towards lower birth weights. And again, within the advanced age group, they had higher rates of cesarean sections, particularly if it was their first pregnancy or if they'd undergone assisted reproductive technology. But across the board, caesareans were more common in older women, regardless of their parity, the use of reproductive technologies, and the number of babies on board. But what they found was that these women were generally a healthy cohort, and I think both Prof. Tremelin and Emma have alluded to this. In this older age group, particularly those who are looking at their first baby, they're often going through assisted fertility. They're often of a higher socioeconomic demographic. They're working, they're looking after themselves, they're in stable jobs and they have stable relationships. And so that, to a certain extent, attenuates some of the problems. And they really found that they had generally favourable outcomes. Although the numbers were small, certainly the cohort that they looked at in Victoria often had better outcomes and lower rates of concomitant medical problems than similar studies had shown in populations around the world. So you really can't get too fixated on international data. You have to look at your own local population. And that's where things like this help. Gestational diabetes, as you can see in the top graph, it's increasing with time, and there's a number of reasons for that. But it also increases with age, and proportionally, women over the age of 35 and those over 40 are overrepresented in the numbers of women with gestational diabetes. But it's more than just that. Where you come from in the world plays a huge part in whether or not you'll get gestational diabetes and what your rates are going to be at any given age. Sorry, this is fairly small, but you can see the blue line down the bottom is for women born in Australia. And the rates of gestational diabetes really pick up after about 35 and definitely after 40. Whereas if you come from Vietnam or anywhere in South Asia and going up, South Asia is really that sweep through India, Bangladesh, Sri Lanka, Pakistan. Your rates of gestational diabetes start to go up in the mid-20s. They skyrocket at about 35 to 39 years of age. And if you're from Vietnam, you're pretty much guaranteed, you may as well grab your glucometer with your bounty bag at 10 weeks. So it's not just age, there are other factors to take into consideration. And the other limitation, of course, for a lot of these studies looking at the rates of medical complications in women at various ages, they're data mining studies. They look at population registries and they're prospective. You can't control for all confounders. And the really difficult thing is that we still don't understand why advanced age is associated with the higher rate of pregnancy complications that we see. So independent of any other medical issues, we don't know what is going on with the older woman. And there are the intangibles, and I think Emma alluded to a lot of those. And as she said in her sort of final statements, they think the problem is actually conceiving. Oh, no, it's not. And the women that I see, you think the pregnancy is hard. You wait till you have a baby and a toddler. So while in our community, and that's really what I mentioned before, if you're Australian born, if you're Caucasian, if you're looking at pregnancy over 45, they do have not too bad outcomes, but there are other challenges. You know, at an age when most of their friends might be harassing children for grandchildren, or you would expect to have had your children heading out of home, they're signing up again for babies and toddlers. And all the effects of ageing that make pregnancy difficult make running after children difficult as well. There's perception. My mother was asked the other day whether the photos of children on her wall were her children or her grandchildren. Now, I think the person meant to be carefully polite, but it certainly underscores that people are aware that older women are having babies and that there is a real stigma attached to being asked whether your child is actually your grandchild. The general health and of older people and the demands of raising a child or children, and that applies to men as well as women. And the other thing, and this is a difficult point and got one of my colleagues in Western Australia into one heck of a storm, when he commented that older mothers who are more likely to go on and develop significant medical problems are playing with fire in terms of raising children. Because if you're in your 50s and your 60s and you have to go into hospital for chemotherapy or something like that, it's unlikely that you have parents who are in a position to step in and mind your children. Whereas in your 20s and 30s, you might have grandparental support. You are less likely to have friends who are raising children at a similar age that you can offload your children on. There are all those kind of things. And there's also something that we would see in adult medicine, and probably not so much for those children who are born with no issues, but for those children of older parents who are born with a disability, potentially due to the advanced stage of the pregnancy. When the parents are in their 70s and they still have dependent children in their 40s, and parents come into hospital, there's nowhere for these children. It's very, very difficult. And back to my original point of, if you are under the age of 65, getting residential care is extremely hard. Getting respite care when your elderly parent is admitted or looking at going into high-level care themselves is also very hard. So there are a lot of challenges for older women, or older couples really, when they start looking at children. I think pregnancy is just the beginning. Thank you.